All right, today we are diving deep into Fungemia. When fungi manage to invade the bloodstream, it's a full-blown medical emergency. Understanding how to diagnose and fight these invasive infections is absolutely critical, because getting it right and getting it right fast can truly be the difference between a patient recovering and facing some devastating complications. So, here's our game plan. We'll kick things off by defining the invasion itself, then we'll jump into diagnosis and how to identify these pathogens. After that, we'll cover treatment protocols, then look at control and complications, and finally, we'll wrap it all up by putting this knowledge into practice with a couple of clinical cases.
Okay, let's dive right in. First things first, we need to properly define our adversary and really get a handle on the scope of this threat. So what exactly is fungemia? Well, it's way more than just a positive lab result. It's a definitive sign that fungi are actively circulating in the bloodstream. This is a key feature of invasive fungal disease, or IFD, which is a systemic, life-threatening condition, especially for those patients whose immune systems are already struggling.
Okay, I know this is a heavy topic, but even the world of mycology has its lighter moments.
All right, bad puns aside, let's get back to the serious clinical spectrum of these infections. You know, the term invasive mycosis is really a big umbrella. Underneath it, you've got things like candidemia, caused by Candida species. There's invasive aspergillosis, which often starts in the lungs or sinuses. You have cryptococcosis, a systemic disease. And then there's mucormycosis, an incredibly aggressive and often fatal infection. The tricky part is that the symptoms are often nonspecific, like a fever. But sometimes you do get localized pain and swelling, which makes that initial clinical suspicion so important.
So, with such a wide range of presentations, the key question is obvious. How in the world do we accurately and quickly unmask these elusive pathogens in the lab? The diagnostic process is this really meticulous, multi-step workflow. You start with super careful specimen handling to avoid any contamination. Then you inoculate the sample onto specialized media to coax the fungi to grow. From there, microscopy can give you some quick early clues while the culture is growing, which is essential for the definitive species ID and, critically, for susceptibility testing down the line. And this is where direct microscopy becomes a real game changer. I mean, even before you have a final culture, the morphology can give you a huge head start. If you see broad, ribbon-like non-septate hyphae under the scope, that should set off major alarm bells for mucorrhizae. We're talking a true medical emergency. And it immediately helps you differentiate it from the narrow, septated hyphae you'd see with something like Aspergillus. This really drives home the point that there's no single one-size-fits-all test here. For Aspergillus, the galactomannan assay is your workhorse. For Cryptococcus, it's microscopy and culture. But here is an absolutely critical takeaway. For mucorales, those common fungal markers are useless. A negative galactomannan in a patient with suspected fungal pneumonia doesn't rule out a fungus. In fact, it should make you more suspicious that you might be dealing with mucormycosis.
And this quote points to a huge growing challenge. It's just not enough anymore to identify the fungus. We have to know what it's susceptible to. The rise of azole resistance and Aspergillus, often tied to these specific genetic mutations, means that a drug that worked last year might not work today. This makes that susceptibility testing absolutely essential for choosing an effective therapy. So, once we have a diagnosis in hand, how do we launch the counterattack? Let's look at the treatment protocols.
Okay, this table lays out our primary arsenal, and you can see some very clear preferences. For invasive candidiasis, you start strong with an echinocandin. For invasive aspergillosis, voriconazole is the go-to, as long as the organism is susceptible. And for the really aggressive infections like cryptococcosis and mucormycosis, we bring out the big guns. Induction therapy with liposomal amphotericin B, often in combination.
Now, I want to pause on this number for just a second, because it is absolutely critical. For mucormycosis, the recommended dose of liposomal amphotericin B is a high 5 milligrams per kilogram per day. This aggressive dosing is vital to combat this rapidly fatal infection. That should be a key clinical takeaway, for sure.
Of course, we all know children aren't just small adults. and their dosing requires careful weight-based adjustments. Voriconazole, for example, has a totally different dosing strategy in kids. And a major advance highlighted here is the prophylactic use of fluconazole in high-risk neonates, which has been proven to significantly reduce the incidence of invasive candidiasis. That's a huge win.
The fight doesn't just end with a prescription, though. We also have to think about the public health side of things and the potential for long-term, devastating complications for our patients.
So, beyond the medication, infection control is paramount. Sure, hand hygiene is the foundation for everything, but for candidemia, the single most critical intervention is source control. Promptly removing all intravascular catheters isn't just a good idea, it is a mandatory step to reduce mortality. And if fungemia isn't brought under control, the fungus can set up shop in other parts of the body, causing these devastating secondary infections. The eyes are a really common target, leading to ocular candidiasis, but it can also seed the spine and bones, causing osteomyelitis, or even the heart, leading to life-threatening endocarditis.
Okay, let's try to crystallize all this knowledge now by applying it to a couple of quick clinical scenarios.
Okay, think about this high-risk patient population. They're neutropenic, they have a hematological malignancy. The key here is the need for early detection before things can really get out of hand.
The answer is serial serum galactomannan testing. This biomarker lets us detect the Aspergillus antigen circulating in the blood, often well before any clinical or radiological signs even appear. It opens up a crucial window to start preemptive therapy and get ahead of the infection.
So for this case, think about what your priorities are in a critically ill patient. What's going to give you the best shot at rapid clinical control right from the very start? The preferred agent here is an echinocandin, and the rationale is all about its potent, broad-spectrum activity against most Candida species. Yeah, you might be able to step down to fluconazole later on, but for that initial therapeutic punch, an echinocandin is considered superior for achieving rapid clearance of the infection from the bloodstream. And that leaves us with a huge, critical question to think about. With resistance to azoles and other drugs emerging globally, think about pathogens like Aspergillus or multi-drug resistant organisms like Candida auris. We have to constantly ask ourselves, are our current strategies, from diagnosis all the way to therapy, robust enough for what's coming? Something to chew on. Thank you for your attention.